Salpingectomy is the surgical removal of one, unilateral, or both, bilateral, fallopian tubes. Fallopian tubes allow eggs to travel from the ovaries to the uterus. Salpingostomy is a procedure in which the contents of the fallopian tubes are removed by making an opening. Oophorectomy or ovariectomy is a surgical removal of one or both ovaries. Salpingectomy, complete or partial, unilateral or bilateral. Through a small incision in the lower abdomen just above the pubic hairline, the physician removes part or all of the fallopian tube on one or both sides. The incision is closed by suturing. Oophorectomy, partial or total, unilateral or bilateral. Through a small abdominal incision just above the top of the pubic hairline, the physician removes part or all of one or both of the ovaries. Salpingo-Oophorectomy, complete or partial, unilateral or bilateral. Through a small incision in the abdomen just above the pubic hairline, the physician removes part or all of the ovary and part or all of its fallopian tube on one or both sides. The incision is closed by suturing. A patient undergoes a cesarean section and, during the same operative session, the surgeon removes a para-tubal cyst from the patient's left ovary. What is the appropriate code to report for removal of the para-tubal cyst? From a CPT coding perspective, the appropriate code to report for the removal of the para-tubal cyst is 58720. Oophorectomy, partial or total, unilateral or bilateral, for ovarian, tubal or primary peritoneal malignancy, with para-aortic and pelvic lymph node biopsies, peritoneal washings, peritoneal biopsies, diaphragmatic assessments, with or without salpingectomy, with or without omentectomy. Through an abdominal incision extending from the top of the pubic hairline to the rib cage, the physician removes part or all of one or both ovaries depending on the extent of the malignancy. The physician takes a sampling of the lymph nodes surrounding the lower aorta within the pelvis and flushes the peritoneum, which is the lining of the abdominal cavity, with saline. The saline solution is suctioned from the peritoneum for separately reportable examination. Multiple tissue samples are excised. The physician also examines and takes tissue samples of the diaphragm. The physician may elect to remove one or both fallopian tubes and the omentum. The abdominal incision is closed with layered sutures. Bilateral salpingo-Oophorectomy with omentectomy, total abdominal hysterectomy and radical dissection for debulking. Through a full abdominal incision extending from just above the pubic hairline to the rib cage, the physician treats an ovarian malignancy. Additionally, the physician may excise pelvic lymph nodes and partially remove para-aortic lymph nodes. In either procedure, the physician makes a full abdominal incision and carries dissection down to the abdominal cavity. The physician excises the fallopian tubes, both ovaries, the uterus, and the omentum, which is a membrane containing lymph, blood vessels, and fat in a protective layer that extends from the stomach to the transverse colon. The physician removes or reduces metastatic ovarian cancer implants from the abdominal cavity. The abdominal incision is closed with layered sutures. Bilateral salpingo-Oophorectomy with omentectomy, total abdominal hysterectomy and radical dissection for debulking, with pelvic lymphadenectomy and limited para-aortic lymphadenectomy. The physician additionally removes pelvic lymph nodes and a portion of the lymph nodes that surrounds the lower aorta within the pelvis. Bilateral salpingo-Oophorectomy with total omentectomy, total abdominal hysterectomy for malignancy. The physician performs a bilateral salpingo-Oophorectomy with total omentectomy and total abdominal hysterectomy to treat a malignancy. A full abdominal incision is made extending from just above the pubic hairline to the rib cage. Dissection is carried down to the abdominal cavity. The physician excises the fallopian tubes, ovaries, the uterus, and the omentum. The supporting pedicles containing the tubes, ligaments, and arteries are clamped and cut free. The uterus and cervix are removed along with a narrow rim or cuff of the vaginal lining. The vaginal defect is often left open for drainage. Attention is directed to the omentum, a membrane of lymph, blood vessels, and fat that forms a protective layer that extends from the stomach to the transverse colon. The omentum is mobilized from the stomach and colon, divided from its blood supply, and removed. The physician inspects the abdominal cavity and removes any metastatic lesions. The abdominal incision is closed with layered sutures. Salpingectomy, salpingo-Oophorectomy. Through a small incision just above the pubic hairline, the physician creates a new opening in the fallopian tube where the fimbrial end has been closed by inflammation, infection, or injury. The procedure is generally performed microsurgically in order to do an accurate repair.